quite interesting when PVCs can lead to occlusion in this lipid topic on lipoprotein as well. So the first case here is a 44-year-old young guy. His birthday is usually is in February 1979. So the first event, the first index presentation he had chest discomfort was again somewhere near his birthday, so in January 2022. He had chest discomfort at the time. You can see this is his right coronary artery, which is patent in 2022, mild disease at the time. But you can see here is not very severe proximal electric stenosis, which was treated with a drug-eluting stent. So that was about 3 years ago. So here you can see it's been treated in a normal way with IVUS guided, treated with drug-eluting stent, and he's been well. And like in all cases, patients who's been well, he's been on DAPT, he's been on statin plus ezetimibe, and he's on ARB as well. So generally well, but as you can see, usually after they feel well, they don't come back for follow-up. So last was seen in 2023, he was taking a single antiplatelet, statins, ezetimibe, and ARB. So he's yet no follow-up, but just taking medications. So again, in his birthday this time again, so that was 2022 in January. His birthday is in February, and he was watching a movie with his wife. And he said something very strange. He just felt like he's going to collapse. He denies any chest pains or only maybe a little bit of throat heaviness, mostly palpitations, near cervical lightheadedness. So he went to another hospital, so he was watching a movie somewhere in Surabaya there, and he went to the A&E there, and they said that he had atrial fibrillation. But we don't actually have the script that he has requested to come to our center. So that was in February 2025, a few months ago. So this was his ECG when he came to see us at the time. He had this funny ECG where he had pauses, he had atrial tachycardia, but we didn't see any atrial fibrillation at the time. And he's walking around, and they said, I don't feel so well. So we did normal cardiac enzymes, check his troponins, it's all negative. Not much chest pains, however, maybe a slight throat discomfort. So we monitored him. Again, when his telemetry, we see so many arrhythmia with pauses, he's young. So we proceeded for a CT scan anyway, just to see his stent. And to my surprise, he has occlusion. So this is his coronary angiogram. So he had a stent and his proximal LAD. And then you will see that his RCA is a subtotal or total occlusion with sort of breaching collaterals. That was what I had when I was in the angiogram. So it was like a smallish, non-prominent right coronary artery, probably occluded, I don't know how long, but the symptoms were a few days old. Occluded with bridging collaterals. Well, he had the symptoms a few days old, I'm not sure exactly when it was occluded. Cardiac enzymes are not raised, no chest discomfort, maybe the throat felt a bit tight sometimes, but otherwise. So the question really is, do you treat or not to treat? So we see this sometimes in the coronary angiogram where the small right, if there are no symptoms, I would probably leave it alone. But for him, because of the symptoms, he had atrial tachy or runs of atrial tachy, the pauses, arrhythmias, I decided to open up the right coronary artery. So, and I was assuming that it would be straightforward RCA with a soft wire, but not so easy. It was just a GR catheter. Initially, with a soft wire, the bridging, as you would hope, would be quite soft. It wasn't, so I had to later on change to a microcatheter. And I think it was a guide wire that needed to cross the lesion. So it was a bit strange. I mean, I'm treating someone who's got a smallish RCA with a CTO wire. So I was thinking in my head, should I do it? Do I need to do it or not? So anyhow, because of the symptoms, you can see even with the coronary angiogram, there were a lot of arrhythmias, so the heart stops, pauses, and not so straightforward. It was not like I thought the wire was just swing and just balloon instead, but the wire went subintimal, a bit of the branches here. But eventually we managed to get it across, down to the right coronaries, the guide wire. And even with that, I had to use a very small balloon course, the microcap can go down. It was like a 1.5 balloon, so it was a bit funny. Like we really took it as like a CTO vision, and finally we managed to get it down and stented with a dollar stent. So this was the final results. So not as big or semi-large, but if you do the IVUS, the intravascular ultrasound, you can see that actually the proximal line is quite big. So it's a 3.4 or 3.5 vessel, so then post-dilated to a 4 diameter. So it's quite a sizable proximal RCA, but maybe non-dominant A. Okay, so it's an interesting case because it's smallish, a lot of symptoms, and the question is will it treat or not. In someone who had no disease in the right coronary artery 3 years ago. So it's progressed over the last 3 years. Anyway, I also shared with our colleague Rosali, and he also initially asked me, it's a small right, I mean, do you need to open up the RCA? Anyhow, I told him the symptoms, give him the benefit of the doubt, we opened up the RCA. There was no documentation of AF, so for him he said, no need to give any NOAC, let's do a 7-day monitor, get him a smartwatch to monitor for any atrial fibrillation, and not for a NOAC yet because of no definitive atrial fibrillation. So we did the 7-day Holter. It's very interesting. I don't know what it is. Well, I suppose we have to assume it's related. So if you look at the 7-day Holter, this is day 2. He still has a lot of his runs of like atrial tachy, atrial PVCs, and then the pauses. So as you can see, day 1, and the top 2, it's SVT or PAC, and then you have the day 3 symptoms, and you have the day 4, day 5, and day 6. So you can see that the atrial ectopics, the PVCs, the SVTs has reduced quite dramatically from day 1 to day 3 to day 5. And even here from the EasyPro Holter, you can see that the amount of percentage of SVT has reduced from day 1 to day 2 and day 3, not at all at day 4. So it's very nice to show and document that the amount of PVC has reduced over time. So in follow-up, his right is like back to normal. He's back in sinus rhythm, no PVC and no arrhythmias. And because of the speed or where he had the coronary angiogram in 2022, it shows mild RCA, and we did the lipoprotein A, and he had a high lipoprotein A levels, both was about 150, 160. So you can see that his LDL was a bit high because he was not being followed up, and he was given inclisiran somewhere during the index procedure. So you can see his LDL is like less than 1, so less than 50 milligrams. And of course, the LPA levels has also reduced since he had the injections. It's another follow-up now, so that's pretty interesting in this case. I've got a short second case I'm going to share as well. This is another guy who 35 years old, and he was flying to New York. He's one of the investment bankers, very young. And when he arrived at the hotel in New York, he had some chest discomfort, and again, he was treated with chest discomfort, and he was sweating. So in New York, he was treated with a few MRI. He needed one stent to his right coronary artery, and residual stents on the left main and LAD. He was treated with high-dose statins, so this one, Atova 80, he's at around 10. So you can see this was his index procedure in New York where he had the RCA infarct, which he was being treated with a stent. Just of note, he has his RCA was not too bad, but recently even his RCA was stable, so I had to put a new stent. So that was like 2 or 3 years ago. And this gentleman, the left side, he's only 35 years old, also has stenosis. He's got proximal ostial LAD, distal left main stenosis. But because I'm not keen, so I did IVUS and FFR because he's so young. So IVUS has got blood burden on both sides, about 50%, but FFR is negative. So for him, I've opted to just leave the left main LAD and set alone. That was about 2 or 3 years ago. He had chest pain 3 months ago. The left side is completely normal, but also his right coronary artery had progressed. I can put another stent in his proximal artery. His LPA is very high. His LPA is about 192, so the cutoff is about 120. So he's a young guy, a very high LPA, and he got heart disease, and he got very high LPA, your cardiovascular risk increase. So for me, as in my practice, anyone below 50 years old who's got pretty advanced coronary artery disease, I will check for the lipoprotein level. So you can see from this gentleman, his LDL is so low because of the high statin, but LP remained very high before treatment, and then he was started on Occlusion at the time. So you can see both his LDL and now his LP has reduced as well. So I think you need to be careful. Young patients, LP is pro-atherogenic and pro-inflammatory molecules which are genetically determined. So if you follow the guidelines, everyone should have at least once in a lifetime, you should measure their LPA level. The difference between LDL and LPA is that you have a tail, the Kringle tail, and the Kringle tail can make your LDL more sticky, more inflamed, and more atherosclerotic. So we need to monitor this in young patients with coronary artery disease. So I think my last slide says that kind of in the first case was a bit strange. It was my first time seeing sort of arrhythmia with sort of SVT or right atrial tachycardia, big pauses, and it can be indicated for recent ACS. Despite reduction in risk factors, you need to consider lipoprotein as part of your risk assessment, especially if you have family history of premature heart disease or a person with family history of heart disease as well. Thank you very much.